I'm so excited for everyone to come back to our Echo, Project Echo on substance misuse and addiction. I'm working on my terms, as Dr. Zuha has talked to us about. And today we are really lucky to have an adolescent specialist, Dr. Jesse Barondeau, come and present our topic today. Dr. Barondeau is a board certified adolescent specialist. I'm trying to look for your bio, Jesse, that I promised to read today. I feel so disoriented.
Well, that sounds okay.
Hi, Jesse. But I think it's also a great chance for everyone to know that we are still lucky and I hope that it's forever, lucky to have an adolescent specialist in the state of Nebraska that you can refer to if you have needs for your mental health, gynecological or adolescent needs. And then, oh my gosh, I'm in the like 30,000 emails, Jesse, that we had yesterday to talk about today's topic. So I'm going to stop being flustered because we're already behind and just say that Jesse will take us into these slides and then we'll do a case. So I'm going to turn my mic off, let Dr. Barondeau handle things and get logged on and centered. Thanks again for your understanding in my usual chaotic place.
Thanks, and yeah, it sounds like that's definitely a curveball for the day there. Is there so I was going to share my screen, but it looks like somebody else has it up there. So am I not going to have to worry about clicking through things then, or do I? Because I don't think whoever put that up there.
Janine, do you want to allow Dr. Barondeau to be a host so he can do his own slides?
Absolutely.
Okay, thank you, Janine. So Jesse, if you'll just take over host, then you can drive your own slides.
I'll see if I can pull this off here.
While Dr. Barondeau's working on that, thank you, Dr. Smith, for reminding me. If everyone could put their name and their affiliation in the chat so we can take attendance. And then I'm not sure who came unmuted accidentally. Okay, and so just a reminder, and then we'll have the CME code at the end.
You need a flu shot still? And when you were gonna
I think Michelle, someone is unmuted.
Is the slideshow going through now?
Yes.
It looks like it is on my thing. Okay. All right. Yes, so click through these on. All right. Kind of go through these little introduction slides here. I guess this is in here for next week is session 8 for everybody at the same time, I believe it's Tuesday at noon. So session 7, overdose prevention and other medical considerations. If you're thinking about managing or trying to help manage some opioid addictions, other kind of addictions in your clinic. So we'll kind of get going here. There you go. That's me. And again, yeah, I'm happy to help out anybody across state for adolescent health, gynecology, behavioral health, sports stuff, ADHD, school challenges, chronic headaches, stomach aches, menstrual cycle things, STDs, all those kinds of things. Particularly a combination of those things where I feel like I come in really helpful versus going to multiple specialists for related things. So anyhow, get going here. So our learning objectives for this, kind of go over strategies to kind of help prevent or reduce overdose risks, identify the role of a naloxone when you're treating opioid overdoses, and then recognizing the other kind of medical considerations to think of while you're treating opioid use disorder, and particularly kind of infectious disease kind of things. I'm just going to go look at harm reduction as kind of the overall goal. With this, we're talking about overdose prevention. We're going to talk about patients that are in the middle of their addiction. They're kind of into it, and probably to the point where they're should be starting to probably have recognition that this is not good for them, but they're not quite to a place where they're ready to stop it. It's really good to remember addiction is a chronic illness, and it will have cycles of recovery and relapse. And And there's kind of a lay way of kind of old-fashioned way of thinking about things, where this is thinking like a moral issue, or they're being bad, illegal, criminal kind of thing. And it's really better to think about it this way, because it's a more honest way, and it's how we can try to help address it. And we're trying to keep people healthy while they're going through this bad cycle, which is what kind of the harm reduction part of this. So again, even if people are not interested in eliminating or reducing their substance use, trying to engage in these services can really help reduce the harms while they're going through that part of their addiction. These things include like education about safe injection and syringe exchange, going over education about overdoses and being prepared for that, and giving them the naloxone to have on hand. Screening treatment for HIV, hepatitis C, and other STDs that may come along with some of those not thinking quite straight, or even just normal behaviors that happen while you're going through the addiction. And then considering PrEP, or pre-exposure prophylaxis for HIV. Engaging in these services allows you to kind of be more easily obtain treatment when they are ready for that. And just kind of what I'm seeing, whether it be a 12-year-old to 21-year-old for starting on any kind of substance abuse, or maybe just experimenting it versus really being addicted to it. It's a little different than like normal pediatric care. I think you get an ear infection, you give antibiotics, and you treat it, and it's a kind of a easy kind of risk reward or treatment thing there. It's not a quick thing. It's a kind of ongoing lifetime thing. And what I'm really trying to do is get them from thinking of the stages of change. So the pre-contemplation, contemplation, preparation, action, and maintenance, and then relapse. And the goal is I'm trying to get them move from where they're at now to the next step. And that's really the kind of getting the motivational reviewing. That's what I'm trying. I'm not necessarily trying to get a kid who smoked marijuana 10 times that never smoked marijuana again in their life. Trying to get them to recognize the problem there. And everybody knows that none of these things are good for you. And I think an easy way to think of it is alcohol, because alcohol is legal and we use it all the time at events, for medical events or family events. But that's also something that could be very dangerous and get people in a lot of trouble. And so I think that's an easy way to think about it in a personal way. But anyhow, so moving on there now. So harm reduction, to kind of educating individuals on signs of overdose. And think of a pediatrician world. I kind of think of this as this makes me think of infants in a NICU or nursery, maybe premature ones who still kind of apnea expels is what this kind of reminds me of. But signs of an overdose: somebody loss of consciousness seems like kind of an obvious one. Becoming unresponsive to outside stimulus. They're maybe awake. Their eyes are moving. They may look at you, but they're not really able to talk back. There's a sign of being overdosed. Breathing very slow, shallow breaths. They're losing that. They're got enough in them that they're losing that innate ability to breathe on their own. Signs of cyanosis: lighter skinned individuals be more bluish, purplish color. Darker skinned people maybe more grayish or ashen appearance. Making the choking sounds, snoring, again, losing that ability to kind of, without thinking about it, this natural ability to keep your airway open. Vomiting, body is very limp, face become very pale or clammy. Easy ways, the fingernails and lips, places where those capillaries are right there, get that bluish or purplish appearance, like another sign of cyanosis. And then there's the pulse being slow. Typically there would be a pulse. They're really, really intoxicated, or there might not be a pulse. But even if there is one, it might be very slow and not very erratic, or not very helpful pulse. Not getting good blood pressure flow. So these are all kind of signs for an overdose. They can kind of help somebody who's in the middle of addiction kind of be aware of these signs, or family members or friends of them. And then if they do witness this, or kind of help people understand how to manage an overdose. So this is kind of a little bit like there's a big CPR kind of stuff, basic life events. But so step one is stimulate, awake, yell their name, sternum rub, or kind of things that kind of alert them, keep them awake. If you're able to, if you have naloxone available, you want to use it. You don't want to hesitate. You just want to use it. And you want to do one dose about every 2 minutes. Injectable, I would think I never actually had to use one of these in my own real experience, but I know the injectables, you got to dry for the entire vial and inject it into the thigh muscle. And just from what I've seen, that I think that would be a little more complicated to use, but that may be what they have. And then nasal, which I think is what the kind of the universal thing that people want kits for EMS and different kind of places, a little bit easier to use. And what is you want to apply? You want to stick it way up the nostril, one nostril at a time. And it's kind of like in a thing with your finger and a plunger thing. And you want to basically stick it all the way up the nose, up to where your fingers are hitting the nose, and then push the plunger in all the way. And what happens is it absorbs through the sinuses. And you do it in one sinus on one side or one nostril. And you want to wait every 2 minutes. And this is kind of where I think people in that situation would be kind of nervous. 2 minutes may feel like a really long time. But you want to give it the full 2 minutes before you do the second dose. Personally, if you do it too quickly, you might end up giving a lot of it, and then that might make the aftercare more uncomfortable as they're going through the withdrawal. But that's that part. And then while you're doing this, or right afterwards, depending on how many people are there helping out, if you're by yourself, you want to call 911. Then kind of explain, hey, someone in here is not responsive, they're not breathing well. I'm concerned that they're overdosed. Step 4, start providing rescue breaths, and this is where I think a little CPR differs a little bit. And in CPR, the typical thing, you want to do chest compressions first. And it's again, it's still, if they don't have a pulse, and you're kind of going through that, you might need to do chest compressions as well. But most of these things, they might be just not breathing very effectively or not at all. So you want to get those rescue breaths in there. Again, get them into their head tilt in the back, so you can pinch your nose, put your mouth on there to form a good seal, and give one breath every 5 seconds like you would do for CPR. This might be something you might more likely be do this ongoing until EMS can show up. If they start breathing regularly on their own, then eventually you want to roll them over to recovery position on their side, so you don't have to worry about vomiting and aspiration and that kind of stuff affecting things. And then in the aftermath of that, if the naloxone kicks in and they're doing better, you want to be gentle with them and yourself, because it's a stressful situation. Be gentle with them all, particularly because they're going to be going through withdrawal. They're going to not be feeling very comfortable. They'll be alive, but they won't be feeling comfortable. So they may, and also they'll be disorientated because they will not be conscious of the point before that happened to where they're at now. So if they wake up in the ambulance or wake up where they're at, they're going to feel really weird, and awkward, and uncomfortable. So, that's the management of an overdose. And trying to prevent overdoses. So the practitioner should assess a need to prescribe naloxone for patients. Again, if they're getting medication-assisted treatment, this might be something to have on hand in case they go through a relapse or they have the situation. So yeah, here's the following tips that can help patients or their loved ones to kind of avoid overdoses. Taking medicine as prescribed by a practitioner. If somebody gets an opioid prescribed, not taking it too often or not doing it more than they should. Don't borrow somebody else's medications. Don't use alone. If you are using it, you kind of use it as recreationally or addicting. Make sure you're with somebody by you, so you can't accidentally or overdose without that help there. Don't take more medication that is often than what is instructed. Don't mix pain meds if you don't want to use with alcohol, sleeping pills, or other drugs of abuse or illicit substances. Create a plan and know how to respond if something happens like this, and dispose of unused medication safely. And these are good education things, particularly I think for families, patients who are in the process of trying to stop, but there's always that chance that they'll have that relapse, and family or friends that maybe be able to help them out while they're going through this. I guess it all depends on where they're at in their addiction status. If they're at this point, they're probably to that preparation, maybe even maintenance stage here. And there's just that risk that they might slip back out of that. Then go through pre-exposure prophylaxis. So again, get into the kind of helping them avoid an infectious thing that they might get while they're going through this addiction, that even maybe when they get past the addiction, then this stuff will still be stuck there, and try to help them avoid this kind of stuff. So HIV PrEP, pre-exposure prophylaxis. This is something that is honestly not that hard to do, but it is kind of a workflow thing and kind of getting used to the medicines and how to do it. So there's a little summary of guys from the AAP guidelines for this, and you can get CDC has some great resources for this as well. For who should be good who would be good ones to use this for, or considered in. Obviously, if they have a sexual partner who's HIV, they're in a high prevalence area for HIV. They may be somebody that kind of reports, they do have sexual contact and they don't always use barrier protection that often. Some of these things may kind of seem kind of obvious. So it's something that maybe you not always think about. If you hear in the story, you might think, oh, HIV PrEP is something you should consider. Maybe something to kind of think about as being something to throw out there. In a lot of these cases, you may not know that they're in these kind of high risk situations. So sometimes it can be a good idea to kind of throw it as an idea, so they can maybe come to you and say, hey, yeah, I know I'd like to consider PrEP, because some of these things are kind of, again, very personal. Even if they have a good relationship with you, they may not be comfortable coming out and saying that they are having lots of sexual partners or they're not using condoms. They may feel kind of guilty about that. So maybe just throw out this as an idea of something to consider, so they can say they want to use this stuff, even if you don't know all these details. Of they might be somebody who would be useful. It'd be a good idea for them to use this. And also getting into the second category there, the more the sexual active use who use injection drugs. They kind of have two things that I may set them up for getting HIV. So anyhow, there's a lot of thought about just, you don't necessarily need to prove that they have these criteria to get that, but if it's something they would be interested in, then you would kind of assume that they might be experiencing these things or thinking about that, or having different partners and stuff like that. Maybe they're engaging in sex for drugs or money, or maybe they're in a sex trafficking situation and you don't know that yet, and they're not willing to tell you that. There's many different scenarios you can think of where this would be good for them. And you go through all the different clinical eligibility for PrEP. You have to make sure they don't have HIV to begin with. You want to make sure they don't have HIV. Then going through the hepatitis B, check on renal function. The prescriptions for this, the first one there, the TDF FTC, that's Truvada, and the second one is Descovy. Truvada is probably used most commonly. The number for people, that's one that's approved for teenage youth, the minors. There's other little caveats. The second one, the TAF one, is a little better for if it has to be some subtle renal function concerns, but it's also not approved if you have risk of getting HIV through vaginal intercourse, like female partners. Anyhow, so there's different little caveats, but some of those things are, if you get into using this, they're not that. There's a lot of little tidbits to get into. But most common people usually use Truvada for this. Prescribing PrEP, basically, it's you do a baseline checks for HIV testing. You want to check their creatinine, their renal function. For most baseline patients, you do Hep B testing and see what their immunity status is or vaccine status. And if they're kind of okay, most people you start Truvada for them. There may be some other subset of patients you might do Descovy instead, but mostly it's Truvada. Here's kind of a lab follow-up for that. The renal function is a big thing. There is a little bit of bone health is the other kind of risk for this. There's I feel like a lot of these different kinds of things in this category. Worrying about bone mass density loss can be another subtle concern. But for the most part, these are pretty safe medicines to use. So you have all these baseline testing you do, get the creatinine clearance, but also the other STDs that you would screen for when they're going through this. Then every 3 months, basically, come back in and do repeat HIV tests and kind of go through the other STDs, and then go through their ability to be compliant with the medicines. Because you don't want to skip days very often. Basically, you don't want to get HIV while you're on this, because then there's a concern they may be building resistant kind of HIV and affect treatment later on down the road. And they do have come out with Apretude is an injectable form of this, so it's every 2-month injection, I believe, rather than the daily pill. So kind of thinking along the lines of doing Depo-Provera rather than daily birth control pills. And that's relatively new. It's something out there that maybe probably in the long term, you're probably more often used than the pills. Just thinking how difficult it is to comply with an everyday pill when you're not sick, kind of thing. And there also is a non-daily oral PrEP that is approved, and you can do this. I find it would be a little bit complicated, but for certain people, this might be easier. Maybe if they're not having sex frequently, or maybe once a month, kind of thing, or it might be random. Basically, was you could take 2 pills of like the Truvada 2 to 24 hours before sex, and then you take another pill 24 hours after you had sex, and another one 48 hours after sex. Might be easier to take the daily, particularly if you're not in a regular sexual practice at the time. also feel like it can be a little bit sporadic. You have to kind of know a little bit ahead of time that you're going to have sex there, or you might have sex. So, but there's another way of doing this. Anyhow, so that's kind of the HIV prep planning. Then you got hepatitis C virus. The screening for this has kind of changed over time. The goal of this is to diagnose and treat chronic hepatitis C to kind of reduce, morbidity, less health, end-stage liver disease, hepatocellular carcinoma risks over time, reduce mortality in the long run. You could do HCV antibodies that tend to become about 6 weeks after exposure. And then also usually reflex RNA PCR testing that comes with that. Chronic HCV infections, usually that's after you've had it for more than 6 months. Most children will be asymptomatic. Some people will spontaneously clear this on their own. But if you do catch someone, to help with lots of follow-up, it's better you kind of start treating them even if they may clear it on their own. For myself, this is something I never really got used to checking for this all. I kind of got used to the old paradigm for this. Kind of screen kind of as needed based on risk factors and their age. More kind of a newer paradigm on this is kind of more universal screening, check at least once in a lifetime after age 18, risk-based screening before that. I suppose you might even screen it more than once. That's what I get with once in a lifetime. Maybe you check once in 18. I feel like you might want to screen again after this, particularly if they may be at risk for catching it for other reasons after 18. Kind of what changed, the more of a higher cure rates with more of the direct acting antivirals that we have now. Cost of medications has gone down far enough that it's more reasonable to screen for more universally and be more likely to treat it rather than maybe waiting to see if it goes away or be more selective in your screening. And the cost benefit just changed. It became more apparent to go ahead and treat people if you do detect them on this, even though they're asymptomatic at a younger age. I'm not going to go through all these, but here's a list of different antivirals that are out there for this. I'll be honest, I don't have a lot of experience for the actual treatment of this. I probably would refer to GI infectious disease to help out with this. But these are some of the more different medication regimens that are out there now to help treat this. Again, the treatments become cheap enough that the risk benefit reward for the screening process has changed. So anyhow, who's eligible for a simplified treatment versus who's not eligible. There's a kind of a pre-treatment assessment that you go through here. I think most younger individuals would be probably okay to do the treatment for this. And then I'm going to check for some drug-drug interaction assessments, education on this, and then getting into the pre-treatment laboratory testing. Anyhow, there's something to get into details if you were going to start adopting this more in your practice, something to consider getting. It's gotten easier to do, and you could do it more. It's cheaper than it used to be. So there's a couple recommended regimens that are out there. The top one, again, if we're taking our teenagers, the top one would be the one that you'd use more frequently. And the kind of the regimen that you get into this, that kind of reminds me of a little bit of like a course of kind of a TB treatment kind of course. It's kind of a long regimen of daily pills that kind of until you kind of clear it. Again, headaches and fatigue, they are the most common side effects with these. If you're monitoring things, check for hypoglycemia if they might have diabetes at the same time. If they're on anticoagulation therapy, you might have to adjust the monitoring of that a little bit. For other patients, there's not really a monitoring thing to go through. Just tolerance of the medicine and ability to continue taking it through the course. So then treatment of injection drug use. You can still use the treatment for hepatitis C even if they're still using drugs at the time or they're still having unprotected sex. And again, you still want to do the risk reduction support while they're on this, and then you would still want to repeat the HCV testing annually after they've gone through this. And pregnancy, if you have hep C during pregnancy, then you don't want to use those antivirals. So you would not use that while you're pregnant, and you get retested after delivery, and then you might resume after that. And then the infants can be tested. So maybe after a couple months of age to kind of learn what their status is at the time. So yeah, that's kind of the HIV, hep C, and then along with it, the other I feel like when you're doing those things anyways, you would you do the Tech-for-Gun Committee and syphilis as well. As a reminder, so I was always best look at addiction as a chronic illness, and expect the recoveries and relapses is kind of part of it. Again, our kind of whole goal in this stuff is kind of if there's somebody's going, know they can go somewhere to get safe injections, safe clean syringes. If they know they're going somewhere that's helping them through this, then once they're able to get to that point where they're okay, I'm ready to kind of get help to stop this, they'll know they have somewhere to go for this, rather than you don't want them to feel like, I guess, the judgmental kind of stuff and feel like they're guilty and bad. They're going to experience all that while they're going through the drug use. If they're going somewhere to get clean needles, they don't really want to be doing that. They're doing it because they're trapped and they have to. So if they're going to a place that can help them through this stuff while they're going through it, then that same place may actually be a place where they can help start the road of recovery when they're ready to start doing that. There's resources for all that, and then I think get into the case presentation here. Sharon, I don't know if you're going to present this part or you're still on or not.
I'm sorry, Jesse. My fingers. I have a little Raynaud's, and sometimes it doesn't recognize my finger. So I'm pushing, trying to not leave you abandoned in this. So your slides were really helpful. I think before we go into cases, though, I just want to open up if anyone has any questions about Narcan and logistics of getting it or prescribing it. I hear all the time that you can get, at least every person can get one free one. Does anyone else actually done that?
I have spoken to the Coles at Midtown and confirmed that I could walk in and get it if I wanted it. I just haven't made it over there yet.
Okay.
I think all the CHI clinics that are affiliated with the hospital in town have it. There's a huge list of all across the state of Nebraska on the DHHS site to obtain them. And you can do it without a prescription by state law in Nebraska.
And the website has, I think, a list of all the pharmacies that are carrying it.
Okay. And I have seen it at CVS behind the counter, like where they keep their nicotine withdrawal products. So I'm like Lauren, where I talk about all the time that I want to get myself a Narcan. But I think maybe this is another motivation to just actually do that and have that available. I think about it when I'm flying. But does anyone else have any questions about that or PrEP or Hep C treatment for Dr. Barondeau? I really loved, Dr. Barondeau, how you framed it as harm reduction. And so I'm going to present this case, and I am going to be very transparent that I did not succeed in the way that, and the reason why this case sticks with me is that there were so many lost opportunities or missed opportunities with this case because it's a little bit new to me. I don't feel like harm reduction was part of my med school training. I don't know if that's an excuse. Anyway, it's just so when I present this case, I'm being very vulnerable that there were lots of things that were not done in the ideal way. So I'm just making up a name. This is not his name, but Cole is a 17-year-old male who comes to urgent care in the evening with concern for some redness and a sore in his pubic area. He shaves his pubic area, and he'd shaved a couple of days earlier, and he noticed that there was an area that he thought was just a typical ingrown hair, but now it's definitely bigger than just a typical ingrown hair. It's warm, tender, and it's draining some pus. And so he is very concerned about that. When you meet Cole, he's a little bit elevated. He's talks kind of fast, gets up and walks around a little bit, and then, sits back down and paces a little, seems a little bit pressured, but, you've never met him. I've never met him before. So I wasn't sure if some of this was his temperament, nervous to talk about his privates with a lady, and then when I go back out, because we put some EMLA down on the area. I look through the chart and I see that there was some notes from the social worker about him recently being released from rehab and his history of both IV and inhaled methamphetamine use, marijuana, and nicotine by vaping. And so then his vitals, he's a little bit tachycardic with a little elevated systolic blood pressure, but he doesn't have a fever. I will just say that he's a thin white male. He has a couple of tattoos that are not like homemade, they're professional tattoos on his arms, and some cuts along his knuckles and hands, like he has just some excoriations. He works at a food place. He works at Panera, and so then he has this small abscess on his pubic area that we were able to drain. When I talked to him about substance use, he does admit that he's relapsed. This is the day after Valentine's Day, and he had part of the shaving was in preparation for a date with a boyfriend that didn't go well. And so was had a breakup. Was disappointed in himself for his relapse, but wanting to recover. So we talked about reaching out to his sponsor. But he is a man engaging with sex with a male, not using condoms, and using injectable drug use. So I'll just open up with Dr. Barondeau and the discussion of what would we do in a primary care setting versus an urgent care for a young man who has these risk behaviors.
Yeah, well, some of the stuff there's good information that he's already been involved with some care, so he probably is aware of some resources himself.
Right.
But it definitely said like how long he's been there, and kind of going through, kind of getting back into that again, and kind of reestablishing some of that. Just kind of getting back on track since he's got off track.
Yeah. So
Um,
things that I thought of in hindsight is we didn't do any testing for STIs there. Whether this was I mean, to me it was an ingrown hair, but could it have been syphilitic? I don't know. HIV, Hep C, sort of testing as an opportunity and a touch point to discuss and do that testing. Asking about where he gets his needles, and if he has access to clean needles. I did not have that discussion. And I don't know what resources we have in the state of Nebraska for clean needles.
That's good. Honestly, I don't know exactly where that would be either. I'd have to look it up.
I know.
Yeah.
Because I feel like there are some states that have needle exchanges through just even like a Walgreens, but I feel like you have to have a prescription for that. And so I did not feel like a great resource to him for that sort of counseling. And then I think PrEP is relatively new to me as a pediatrician to think about. And so would that be something that I could refer him to your clinic for?
Definitely, yeah. That's something we do here, and that you're right. That's that kind of getting that history. Like that'd be something to think about bringing up. You certainly want to start there. Maybe you can kind of refer him or say, "Hey, this is something to think about," because he may have already been worried about it, or maybe he's kind of just put it like, "Yeah, I'm worried about it, but I don't want to do about it, so I'm just not gonna do anything about it." So either do the screening like you said to at least get the thought process. Hey, this is the things to be thinking about this, and we have somebody, or we can refer you to a place to help prevent this, so you can be safe if and when this happens again, to at least avoid those kind of consequences from behavior. But yeah,
so I would have loved if I would have thought, oh, I should refer him to the adolescent clinic to have these wonderful discussions, because uh, 30 years ago, I have a classmate who um, uh, became HIV positive as a young man of 17 or 18 that was just in those early sort of, I don't want to say carefree, but unaware of the, you know, the implications of, you know, impulsive decision making. And so I think back to this interaction, and I think so many opportunities lost. And it was a simple interaction, and that's what made me also think about this case was a lot of our interactions aren't going to be specific. The reason for the visit isn't going to be substance misuse, or I'm worried about Hep C. The reason's going to be I have acne, or I'm worried I have COVID, and then you come upon in the chart these other things that you're wondering, has anyone ask you what you're doing as your harm reduction for these behaviors?
Yeah, that's a good point. I think too, that an urgent care clinic or general primary care clinic, very good point on that. And sometimes it depends where they're at. You're right; they might be presenting for a kind of a sequelae or a further down the road side effect of some of the behaviors, and they can give you a window into that, and then kind of help them. Hey, this is either try to address there if you have time or the ability to that, but a lot of times you won't in an urgent care clinic really have that kind of time probably. But at least you can maybe open up the conversation. Hey, we have places we can send to either adolescent clinic or other psychiatry or maybe STD kind of clinics, other places that might be willing to kind of help give it more of a aftercare or a little more prolonged discussion on that stuff. But it's a good way to capture that though. At least show it, spend like 2 to 5 minutes to like, hey, we have different places like we can help you out with trying to avoid this or help you out while you're going through this. And even in the moment, I'm guessing a lot of times they may be thinking about it in the back of their head, but nervous to bring it up. That's why they go into urgent care clinic to not talk about it.
Right.
And again, if they're like very pre-contemplative, or contemplative, they're liking the drug use, they're enjoying it, they're hooked on it, but they're not willing to quit. They may be very resistant to any suggestions of this kind. But it's still, I think you bring it up in the back of the head. I think you may plant a seed there, or maybe a month or a year down the road, when it starts to catch up, because eventually this stuff will catch up to you. They'll think, you know, maybe I'll go take it up on what that person told me 2 months ago or a year ago. I'm ready to start doing that now. And that's the part where I think it's hard in urgent care clinic or primary care clinic, because you're not seeing that right there. If you just plant those seeds, that might a year or two from now start kicking in. And just where I think it can get frustrating in the moment to even deal with it, because sometimes these patients can be kind of difficult to deal with because they feel like don't want to listen to you or don't want to hear you. Sometimes they might want to. Sometimes they bring it up. They're like, yeah, that's something I've been thinking about a while, and I just haven't had the want to bring it up. Or they might just like, I don't care. I don't need help with that. But if you bring it up, it plants that seed that later on they may take you up on that, or take it up to a different doctor down the road.
There's a question in the chat, but I just had a memory. So last week we did a community in advocacy or community thing with Nebraska AIDS Project was there. And I just remembered that they do clean needle access and exchange for both Douglas County and Greater Nebraska. So I just remembered that as we were sitting here. So Dr. Maskin has a question about your capacity to do oral, genital, or testing, oral rectal testing, STI testing, excuse me, in your clinic.
Yes, definitely. We'll swab those located when we find out we're talking about the sexually contact, kind of see what oral, anal sex, talk about that kind of stuff, and then we'll swab wherever they're having sex at, whatever location. We'll do all those things, and then resources for mental health. So right now, I do a number of the psychiatric stuff, whether anxiety, depression, ADHD, and then sometimes get into if they're kind of possibly bipolar or some of those psychoses. We'll start treatment. If there's more of the psychosis stuff, I'll get them into psychiatry. Within our clinic, I don't have that, but I work closely with both UNMC and and children's psychiatry to kind of get them in there if they're, but I can kind of start them on stuff while we're waiting to get into psychiatry. And also CHI I've worked with a little bit too, because I have patients that come to me that are already at CHI, and so then I'll communicate with them. And we don't have therapy in the clinic right now. I hope we have that in the future. But again, I kind of work directly, visit with different within the system I'm in, but also just there's a handful of private therapy clinics in town that I will work with or talk with.
And you're doing medication prescription and management?
Yes, anxiety, depression, SSRIs, SNRIs, ADHD, and then also we like Abilify, Risperdal, some other antipsychotics. I will definitely use psychiatry if they get more like they may have bipolar or other things going on. It's complex, but sometimes as we all know, it's something that could take a while to get into psychiatry. Just not enough though, so I feel comfortable getting them started on something until we're able to get them into psychiatry.
Excellent. Do you do you do any telehealth clinics for Greater Nebraska yet?
Yes, I see a few patients from like the Kearney, Hastings area, only by telehealth. I try to get them in clinic at least once to get to know them, but I don't make that a requirement just because I know if they're a long ways away, I don't want that to be a hindrance. And I've seen people go to Western Iowa that live 2 or 3 hours away between here in Des Moines that I've seen for things. So I do have telehealth available.
Excellent. Because I see we have our Grand Island clinic, and I think we have some of our AAP members from Lincoln and maybe Kearney on as well. So that might be a helpful resource for them.
It's ideal to see in person, but if they're 2 or 3 hours away, that certainly is not a requirement. Most of what I do would be talking. There's not so much many physical things I need to do for them. And if they need labs, we can order that wherever they're at. So
excellent. Well, I hope this vulnerability in this case makes some people interested or more open to sharing and participating in a case for next week. So you don't have to only present a case where you did everything right. As I know I fixed his groin abscess, but I there's room for improvement in so many other ways. I hope this also motivates all of us to go out and pick up our Narcan for our own personal use. And Dr. Barondeau, I liked how you used that story for alcohol for parents to understand, because I just feel like, and I don't know if you're seeing this, but I feel like we have so many more parents who have normalized marijuana or normalized substance use in their teens, as that's just what teenagers do, and sort of using the example of alcohol is, yes, we have the ability to have alcohol as adults, but we have to do it in a way that doesn't interfere with our responsibilities or is unsafe. So it's not ideal, but it's harm reduction.
Yep. And any of those things can kind of catch up with you and without trying. It's not something you try to do, but if you end up smoking marijuana every day or using alcohol more, it's not, you're not doing it because you want to, you end up doing it because you're trapped in it, and usually takes a while before you figure that out. So
there's a comedian who said, you don't wake up in the morning and plan to be arrested at 2 p.m. After you see your girlfriend and have a quick bite to eat. You don't end up with an addiction or a substance misuse problem because that's what you set out to do. But we're here, and so then we need to figure out how to get back into a healthy place. I don't know, Laura and Janine, if it's time to add and I know was never able to log on to the computer and not off my phone, but to share the CME code.
Dr. Barondeau, if you can scroll a little further in the slides.
Oh yeah, I'm still in control of that.
You're fine. Those are your statements, and if you go another slide, I believe it has the QR code. There you go. Thank you very much.